Okay, it's wonderful to be here in this wonderful city. We've already had a lovely day yesterday, becoming acclimatised to Basel, and it's an important city for this conference to be held at. So thank you for inviting us to speak. So I'm going to talk about reaching out and engaging marginalised key populations with urban health services, such as Kirkton Road Centre, which I've been the director of for 30 years until earlier this year, and particularly lessons for upscaling that we've learned from upscaling hepatitis C treatment in Sydney. And I think it follows on very well from the last presentation, which was particularly focused on HIV and tuberculosis. We've had great success in Australia in both preventing and treating HIV, a prevalence of less than 2% among people who inject drugs, and currently a treatment coverage rate of around 93%. And we're fast on the way to eliminating HIV in the Australian context, despite it having actually been at very high levels in the early 80s when we first became aware of that virus. But hepatitis C, no such luck. We have prevalence rates, like many parts of the world, among people who inject drugs of upwards of 60%. And this has been the case for many years, so now we are looking to try to upscale treatments now that that's become more effective. I'd like to start, though, by acknowledging my co-workers here, the people who both ran the clinics that I'm going to be talking about, and, of course, the people who attend those clinics. So going back then to March 2016, Australia was one of the first, if not the first country to make access for all public health policy in relation to the new hepatitis C treatments. Going back a year before that, the Pharmaceutical Benefits Advisory Committee recommended funding of interferon-free direct-acting antiviral regimens, which will be referred to as DAA treatments hereafter. And a few months later, in its documentation, it says access for all to highly effective HCV treatment is a priority. $1 billion was allocated to hepatitis C treatment over 5 years, commencing last year, and this was certainly a watershed moment for which our Federal Minister for Health, Susan Ley, at the time deserves credit. The key features of our program in Australia was that it's completely subsidised by government. No restrictions were placed in terms of stage of liver disease or on whether or not people were still using drugs and or alcohol. There was also no cap put on the number of people who could be treated each year, and also retreating people who were reinfected with hepatitis C was also allowed. Add to that we allow a broad practitioner base to actually prescribe this treatment. So not just gastroenterologists or specialist physicians, but also GPs and junior doctors working under supervision in public hospitals and in public clinics. There was an immediate response, almost overnight, or at least in the first couple of months, where 10% of those living with hepatitis C turned up to be treated. And that exceeded all expectations and was extremely exciting, particularly for someone like myself who, as already mentioned, worked in the area for 30 years, knew that we had a hepatitis C epidemic, and yet we had very ineffective treatments associated with a lot of side effects. That was all that was available, so this was very exciting. However, a year later, that has only increased to 17%, with the uptake declining sharply after the initial rush. So if we just look here, this is a slide showing the broad practitioner base. As you can see from the beginning in March, it was mostly, in fact, gastroenterologists, but very quickly that was deregulated such that by September in 2016, half of the doctors prescribing this medication were not specialists. Here we can see the dramatic increase in uptake in hepatitis C treatment, the red column indicating direct-acting antiviral treatment. So as you can see, we had interferon-based treatments in the brown columns starting in 1997 through until 2014. Bit of a drop-off there because word was already coming through that these more highly effective treatments were going to be available, so people were what we call warehoused. So then we saw this dramatic increase where in 2016 about 32,000 people stepped up to the plate. However, it's estimated that there's still 200,000 people living with hepatitis C who have not yet access treatment. Who's been treated so far? This is wave theory. I guess it's the first wave that's occurred very successfully. That is people who were already well connected to healthcare, had been tested, were ready for treatment. They're the group that are most likely to step up in that first wave. The second wave are people who are currently using drugs, who are hepatitis C positive, might well be tested, know their hepatitis C status, but have not yet been mobilised for treatment. And then there's a third wave of those people who have not yet been diagnosed or identified. And the challenge is to get this second and third wave to step forward, because only then can the elimination goal that we have now set as part of our national hepatitis C strategy be realised. As I mentioned before, already we're well on the way to achieving this goal for HIV. It's now been set for hepatitis C by the year 2026. So in the next decade, we're hoping to eliminate this infection. The barriers to that, though, are stigmatisation, criminalisation, political conservatism. So those, along with the fact that there's no needle syringe program in prison, so that continues to be a hothouse of infection. More than half of the population in prison already having hepatitis C, and the other half being fast on the way. No formal recognition of peer workers and integration, formal integration with clinical services, and punitive measures that target people who inject drugs, is also mentioned by the last speaker. Kirkton Road Centre is a targeted primary healthcare centre in Sydney's King's Cross. This is a red light district in Sydney. I won't read out all of those characteristics, but this is a very low threshold service that focuses on being an affordable, accessible service for those people most at risk. And it includes and integrates services such as an opioid substitution program with methadone and buprenorphine, a needle syringe program, a very comprehensive outreach program. We also work very closely with other services, including NEWA and the medically supervised injecting centre and homelessness hostels in the area. So in 2016, Kirkton Road Centre commenced working in a partnership model to provide FibroScan assessments. FibroScan is the test that's used to measure the stiffness of the liver, and it's a very strong indication of whether or not people have hepatitis C and whether or not those people should be treated. And this is a much better test that compared to, say, liver biopsy, which is a significant barrier for people to enter into hepatitis C treatment. We have a portable FibroScan at Kirkton Road Centre that we can then take with us to other non-health locations, so that we are not requiring people to actually come to Kirkton Road Centre to be assessed. Of course, we are assessing people there, but we also take the FibroScan machine on the road to other clinics and other homeless places where homeless people are, people who are key populations to ensuring that we get access, universal access to those who need it most. So we conduct these nurse-led clinics in partnership, particularly with NEWA and the Injecting Centre, and, as I mentioned, other services in close contact with those people most at risk. The New South Wales Users and AIDS Association is a peer-led and staffed and governed organisation. It gets core funding from the New South Wales Ministry for Health. It has partnerships with a range of different organisations. It's located about 2 kilometres away from Sydney's King's Cross, which is where Kirkton Road Centre is. It's got a long-standing needle syringe program. It does a lot of peer advocacy and referral. And we've been conducting an outreach liver assessment clinic there on site since early of last year. The organisation also provides a buddy system, their own peer workers there at Newer, buddying up with the people who are seen at the clinic to support those people through the treatment navigation system. As mentioned, also we're in partnership with the Medically Supervised Injecting Centre, which I was involved in for its first 8 years. It's the only facility in Australia still, and like the drug consumption rooms here, it necessarily is engaged with highly active, highly marginalised populations. As I say, this is the group that we need to get to and provide access to if we're to reduce the viral load in this population and such that we can actually achieve elimination of this virus. And we've been conducting clinics there. So the results between 2014 and 2017, over 2,000 people were assessed for hepatitis C at these clinics and at Kirkton Road Centre. The average age about 39, almost 40, indicating also the ageing nature of this population in Australia and also elsewhere. 70% about were male, and about 17% Aboriginal. Aboriginal people in Australia are very overrepresented, probably only represent a couple of percentage of the overall population, but very overrepresented among substance-using populations and those people with hepatitis C. So it's very encouraging, particularly because also a history of poor access to treatment, that this project was able to access this group of people in such high numbers. 915 fibre scans were undertaken among 751 people. There's the breakdown between the different clinics, most of them at Kirkton Road Centre, but also at those other outreach clinic locations. Over 1,000 hepatitis C antibody tests were undertaken and almost 1,000 PCR tests. Those are tests to actually confirm that not only has the person been exposed to hepatitis C, but they're still carrying the virus and therefore should be treated. So 36% overall, or 744 people, were diagnosed with chronic hepatitis C and were therefore eligible for treatment. And so far, we've entered 182 clients for treatment. It's another study, but what we've found is that with those people that we've been treating, we've got almost 100% remission rate. So the treatment in this group of people also is extremely successful and comparable to what we're seeing with broader populations being treated across the world. 36% of those people that we have treated and contacted were first engaged in outreach settings, and as you see, there's the breakdown between the different clinics. Just to see the cascade here, you might ask why it is that some 700 plus are eligible for treatment, but not yet 200 in treatment. There is a sort of cascade that happens that we're having to obviously keep ramping up. So here you see the buddy system that I referred to at the user organisation. And as you'll see there, of the people screened, about 20% of those people have completed treatment to date. So just because you're screened and eligible, there's still quite a pathway for people to go through, but we are doing well as far as assisting people in navigating that pathway. This is an important diagram. Unfortunately, I don't have a comparable one for the overall population of hepatitis C patients treated to date, but you'll have to take my word for it. As mentioned, the first wave has largely been those 32,000 people treated to date. Most of that first wave sit outside in the pale purple part of this graph. So they are not current drug users and they are not people currently in methadone treatment. Whereas what you see here, of those 200 or so people that we've treated through Kirkton Road Centre, 41% are currently using drugs, and about 40% of those people are in opioid substitution treatment. So as I obviously try to emphasise, it's to achieve elimination and prevention, treatment as prevention. This is the part of the graph that we need to up the numbers in, and what this partnership model shows is that this is possible to start to get coverage in those inner circles of this particular diagram. So concluding, ensuring universal access to treatment is needed to meet the elimination goal. It is challenging, but it can be done. It will require the development of strong clinical community partnerships. We certainly can't leave it to hospitals. We can't even leave it to low threshold primary healthcare services. We need to get further down into the community to reach these key populations, and that does involve user organisations, injecting centres, homelessness, refuges and the like, so not necessarily clinical environments, and out there onto the streets using outreach models. Policy discussions will need to include representatives of drug users themselves, picking up on what Jerry was saying, nothing about us without us. This is, of course, a guiding principle, and this is how it translates at that coalface level. Flexible low threshold harm reduction service models already engaged need to be involved. Peer support is key to this, also to help navigate through what ultimately is still a challenging pathway for people who don't traditionally access healthcare very well. And this partnership model I've presented here today as a case study, suggesting that this is a best practice model that can be translated elsewhere, and also for things such as HIV treatment and tuberculosis treatment, and for other healthcare challenges that marginalised populations face. Thank you for listening.